Good afternoon, everybody. Thank you to Amy and Mary Jane and everyone at CHIPS for inviting us to participate and collaborate in this forum today. My presentation actually takes up where Mario left off with the cascade, where we saw those very low rates of HIV, linkage to care, retention in care, and viral load suppression in LA County, and describe some of the demonstration projects and future programs that we have ongoing to really address these gaps in the HIV care continuum. So I'm going to talk a little bit about two of our projects, which are what we think are, at the time anyway, a couple of years ago, were novel approaches for identifying, engaging, re-engaging, and retaining HIV-infected people in care. Project Engage, which I'm going to talk about first, is a program that uses respondent-driven sampling and direct recruitment and incentives to identify and link to care marginalized, out-of-care HIV-positive people. And then our navigation program uses enhanced public health investigation methods and modified ARTIS with the antiretroviral treatment access study to re-engage out-of-care clinic patients. And actually, the navigation program is sort of one example of some synergies that we saw between HIV and STDs, where we really adapted these PHI locator methods that historically have been used for finding hard-to-locate people with STDs and also HIV. And we adapted it to really find HIV-positive people who are out of care. And I want to thank Rodri Deers-Davies, who's here, and Nikki James, who run these programs and helped me put together these slides. And I was told that we only had five slides, that we were only allowed to present 5 slides. So I kind of squished several slides worth of data into one. But hopefully it's not overwhelming, and hopefully you can, I don't know if you can see it, but I'll walk you through it. Don't be thrown by it. Okay, so on the left side, under recruitment, it shows our basically sort of study design for these two arms that we have. One is a social network approach where we ask people, HIV positive, HIV negative, it really doesn't matter, if they know people who are HIV positive and out of care. And we incentivize them to bring in people from their social networks. And we pay them $40 to complete a baseline survey, and then $40 for every person that they bring in their social network who's HIV positive and out of care. And then that person who's brought in through the original seed or index case also gets $40 for every person they bring in their social networks who are out of care. And for those of us who have been in HIV for long enough, we know that there is, and actually everyone who's in the HIV world, we think there's this subset of our HIV-infected population, though that unaware group, or even unaware, or even people who know their HIV status but are not in care. And it's kind of been the needle in the haystack for many years, is that we have really had trouble identifying this population. So we came up with this methodology as an alternative way to find this group. So that's one arm of the project. The second arm of the project is this direct recruitment approach, where we have our staff go out into the field to parks and public areas and agencies and try to just interact and find people one-on-one who are HIV positive and out of care. So we propose to use these two approaches to see, could we really find HIV positive people out of care? Because to date, that had been a very difficult challenge. So I am happy to say that we actually have had success with these programs and these approaches, and I'm going to report on some of the kind of preliminary data from the project. So the out-of-care alters are 58 people who have been brought in from our 59 seeds, actually, who met our definition of being HIV positive and out of care. And Roger, you probably have to help me with this a little bit, but they have to not have had an HIV care visit in 6 to 12 months with a detectable viral load, or no care visit in 12 months, or in intermittent care, or recently incarcerated or released from some kind of institution and no consistent care. So that was our definition. And what we ended up discovering is the population that we found most effectively through these methods were a marginalized population. 72% were homeless in the past 6 months. 24% reported some kind of exchange of sex for drugs or money in the past 12 months, and 55% were recently incarcerated. In terms of their baseline care history, when we found them, on average, they had been out of care for over a year, 13 months. The last reported viral load that we had in our HIV surveillance data for them was on average 49,000 copies per ml. So we found a pretty disenfranchised, out-of-care population. Of the 58 people we found, and then this 58 includes people who were recruited through the direct recruitment approach, where I mentioned we have staff who go right out into the field, and also the social network testing approach. I want to mention something about the social network testing approach. Typically in these kinds of projects, you have multiple waves where, a seed brings in alters, and then the alters bring in alters, and then you just have this successive wave, and you run these programs until you've sort of reached the bottom of those social networks. Well, one thing we learned in this project is that people actually don't know very many people who are HIV positive and out of care. If we're lucky, they might know 1 or 2 people. It's the rare exception that we find someone who knows multiple people who are out of care, and then their friends in turn know other people who are out of care. So the networks are actually quite shallow, which wasn't necessarily something we knew. We didn't know that going into it, but it's an important sort of finding of our project. So of the 58 out of care people that we found, 21% themselves enrolled as recruiters, 71% were linked to care. On average, it took our staff about 30 a month to link someone to care. There was quite a variety in that. There's some people that our staff are still working with, honestly, months later, to really get them to a place where they're ready to engage in care. Some folks we have to kind of leave alone and circle back to them later, but our staff, keep them on our radar. But on average, it took about a month to link people to care. And then in terms of average staff time, it was on average 6 hours. But again, there are those outliers that take quite a bit longer. In terms of the project acceptability, and this is only on data for the 28 folks who actually have completed our program. 100% said they were satisfied with Project Engage. 93% said Project Engage helped them get into care. 75% said that without the program, they wouldn't have linked to care. And 100% said they would recommend the program to others. So just in terms of our lessons learned, we showed ourselves that basically incentivized snowball sampling and direct recruitment were effective at locating this hard-to-reach, marginalized, HIV-positive, out-of-care population for linkage to care. And to date, really, that had been a group, honestly, that, at least in my sort of HIV professional career, most folks I know have not had a lot of success finding this population. And then and then just to highlight one of the findings, a large proportion, I mentioned this, who completed the program reported they wouldn't have entered care without Project Engage. And we also found that recruitment was most effective in a non-medical agency setting or public parks, outdoor settings. People who are in care, we sort of started out by recruiting from HIV clinics and spun our wheels a little bit and learned that HIV positive people who are in care actually don't know very many people who are HIV positive and out of care, right? It's consistent with, the literature that says if you smoke, your friends are more likely to smoke. People tend to know people who are more like them. So anyway, that's Project Engage. And we're actually hoping to take the kind of lessons learned from this program and scale it up into a sort of developing county-based linkage to care program that we have planned. Okay, so now I'm going to talk a little bit about another project we have. So whereas Project Engage focused on really HIV positive people who are out of care without a lot of connections to institutions and clinics and hospitals and even somewhat to agencies, but not a lot of connections to medical settings. This program, the DHSP collaboration with APLA navigation program, focuses on re-engaging HIV clinic patients who have been lost to the clinic. So it's we learned, actually, it's a very different population than the population that we are finding in Project Engage. I mean, there's some overlap, but in Project Engage, we're getting that population, we think, who just doesn't show up to a clinic very often. Okay, so we worked with APLA, who hired navigators, and we collaborated with 7 different HIV clinics in LA County and identified over 1,000 patients from medical records at the 7 clinics who, by our definition, that same definition I just mentioned earlier, were out of care. And so they were eligible based on viral load and length of time out of care. And we have the advantage, I really think, of having access to HIV surveillance data that allows us to really see where someone is in care. That data is extremely protected. We have very strong confidentiality procedures in place with very limited access. But we had IRB approval to use that data for this purpose. And of course, we get informed consent for everyone who enrolls in these programs. We don't obviously do anything without informed consent. Anyway, based on those 1,000 or so patients, we eliminated about 300 who it turned out didn't meet our eligibility criteria. And out of our 700 patients who were out of care at the clinics, 28% were actually in care elsewhere. So whereas the clinic thought they were out of care, they actually were in care somewhere else in Los Angeles County. 23% actually returned to the clinic independently of us. So, but the time between when we got that list of patients and when we tried to follow up with them, they had returned on their own. An additional 56 patients actually our navigators called, and they actually, all it took was a phone call to get them to re-engage in care. So 8% of that total 702. But they were never actually enrolled in our intervention. They were, but our phone call from our navigators was what precipitated the call to the clinic. 27% either were not available, we left a message, or they had a wrong number. So we didn't have good contact information for them. And I should mention, as part of this project, we developed sort of access to multiple different databases, because honestly, finding this population is really the challenge, and getting good contact information. For the most part, we got our contact information through the clinic medical records and through our surveillance data. And it was a hierarchical process where that's how we started, and then if we couldn't get good contact information, then we moved on to some other data sources, including our STD surveillance data sets, LexisNexis, our HIV Ryan White Case Watch database, and so on and so on. But most of the time we got our good, usable, effective contact information through either the clinic medical records or our surveillance data. 5%, okay, so 11%, only 11% of the total out-of-care patients were actually located, interested in participating in our program, and had an appointment scheduled. 5% were deceased, 4% were no longer an LA County resident, and then only 2% declined in enrollment. And the way this version of our navigation program was set up is probably many of you are familiar with the ARTIST program, the Antiretroviral Treatment Access Study. It's a modified strengths-based case management program that we modified actually. ARTIST was designed for people newly diagnosed with HIV, and we modified it for this population who's known they had HIV for some time but are out of care. And we expanded the number of visits that could be kept with the navigator, the case manager. We eliminated the incentive. We combined 2 of the sessions, but didn't do a whole lot of modification. But it was modified. It's not boilerplate ARTIST. Anyway, on average, our patients who we enrolled had an average of 7 visits with the navigator. The average number of hours spent with the navigator was 15. 98% of our participants actually linked to HIV medical care, but only 48% were retained in care at 6 months among those enrolled greater than 6 months. So this is an example of why we do demonstration projects and sort of work the kinks out of our programs before we scale them up and have them go live. We learned that although our program was effective at linking people to care, we handed folks off to the MCC team at the clinics. And MCC is a new sort of service delivery model we have in LA County. But we realized that we think it would be retention would be more effective in the long term if our navigators continued a relationship with the patient. So for the next iteration, we've modified this so that actually the navigators stay with the patients after they've enrolled in MCC and for 6 to 12 months. So they kind of work in parallel with the MCC program. And then our patient referrals included housing, substance abuse treatment, mental health services, nutritional services, transportation, assistance with health insurance, and ADAP enrollment. A lot of the obstacles, as many people know, is sort of negotiating the healthcare system and getting through financial screening and finding out your eligibility criteria. And then, the other thing we learned was a one-size-fits-all intervention strategy is inefficient and not client-centered. So for the next iteration of this, we're introducing a 3-tiered intervention, a sort of quick phone call, linkage to care, a one-time motivational interviewing session, and then the more in-depth ARTIST intervention. It's very time-consuming to locate and re-engage the patients. We sort of identified some efficiencies in matching surveillance and clinical medical record data. Before, we tried to find people based just on clinical medical record data. We could eliminate all those folks, for instance, who were in care somewhere else and not waste staff time trying to find them. And then we also, as I mentioned, identified this need for increased retention efforts. So I think I've already sort of hit the highlights. We've sort of proved that we could find this hard-to-reach, marginalized HIV-infected people using incentivized snowball sampling and direct recruitment methods. Expanded linkage retention efforts. In Project Engage may assist these clients. We didn't actually have an intervention as part of Project Engage, but we learned that actually many of these clients really did need a more in-depth intervention than our demonstration project was designed to provide them. And then supplementing clinic information with surveillance is most effective method for obtaining useful contact information for the navigation out of care patients. The one-size-fits-all intervention strategy is inefficient and not client-centered. And as I mentioned, we're going to take these lessons and really try to incorporate them into a county program going forward. Okay, so I will stop there.